So starting with diabetes mellitus and its basics, usually when I looked into the Harrison, it's very subtle and very sublime. Harrison was speaking a lot about the epidemiology, the impact it has in the population. It was like a SPM session. This particular class, I have not gone into core Harrison. I have taken a few points and important points from, but I want you all to be accustomed with the various forms of diabetes, each and every diabetes, how it behaves, why is it so, how the treatment plan differs. That concepts you have to know. So this class is exclusively not from Harrison. I have taken Harrison. I have included all the points from Harrison, but in addition to that, I have taken from lot other sources so that it will be easier for you. So, what is the operational definition for diabetes? As you know, it's a group of common metabolic disorders. Uh, all the disorders will share the phenotype of hyperglycemia. You may have a hyperglycemia alone, you may have a hyperglycemia with insulin resistance, you may have a hyperglycemia with a secondary dyslipidemia, or you may have a hyperglycemia with a syndrome. You may have an obesity or some other hormonal issues along with that hyperglycemia. So it could be whatever be the phenotype, multiple phenotypes. It almost has a baseline tag, which is hyperglycemia. So that is the operational definition. To make it even more operational, ADA states diabetes mellitus is a group of metabolic disorders with carbohydrate metabolism. Either the glucose would be underutilized, either it will not be used at all as an energy source, primary energy source, or on the other hand, it is getting overproduced due to the inappropriate counteracting mechanisms. Normally, in fasting, gluconeogenesis and glycogenolysis has to happen. But in this case, what happens? Impairment happens in every pathways, and that way you will have an overproduction of glucose on one hand. At the same time, you may have an underutilization of the glucose. All will result in hyperglycemia. So just know about the definitions because there could be some age-old professors in your college who may ask you the definition of hyperglycemia, and that is the reason. This is a diagnostic criteria according to the recent ADA guidelines. To diagnose diabetes in a non-pregnant individual, you should have or. Just look into this or. Okay, the patient should have symptoms of diabetes mellitus with a A1C, HbA1c, glycated hemoglobin level of more than or equal to 6.5 percentage. Okay, the HbA1c reflects the last 4 months average, the last 120 days average of glucose. Okay, and we will learn about HbA1c also, and this should be more than or equal to 6.5. So anything from 5.7 to 6.4 would be considered as pre-diabetes, and anything less than or equal to 5.6 is non-diabetic range. Okay, how is it even arrived? It is according to the DCCT assay. So this was one bigger trial, which is a landmark trial in diabetes. And in this landmark trial, diabetes complication control and complications trial, in that trial, they did HbA1c. They used a gold standard method called as HPLC, high performance liquid chromatography, where this particular HbA1c is categorized according to the charge. Okay, so it was a gold standard method, but we have other all methods by which this HbA1c can be analyzed. It can be analyzed with immunoassays, it can be analyzed with enzymatic assays also. But even though they are done, the gold standard would be always HPLC. So they utilized this particular method in this particular landmark trial, and this is considered as a standard. Okay, so anything which matches this standard will satisfy this NGSP certification. What is NGSP certification? National Glycohemoglobin Standardization Program. Okay, this program makes sure that whatever HbA1c you are measuring, in whatever lab it could be, it matches the standards of the HbA1c, which is measured by the HPLC technique during that assay. Okay, so they offer certification programs. Okay, so these certification programs for level 1 and level 2, and any lab which has tie-ups with the secondary reference laboratory, and they have to get periodically on a quarterly basis, they will have to get these certifications. They will have to check their HbA1c, and they have to send the same blood sample for the HbA1c by that secondary reference laboratory. If these two match, and they should have an exact matching, nearly they will have to a good percentage of matching, only then they will be awarded this particular certification. Only then the HbA1c can be more reliable. Okay. Okay, first of all, what is HbA1c? Any idea? How is it even formed? What happens to a hemoglobin in HbA1c? Any idea? Okay, AG. Okay. Any other answers? Is it enzymatic or non-enzymatic? So normally what happens when you have high glucose in the blood, they enter into the red blood cells through passive diffusion. Okay, so through the GLUT1 channels, they enter into the RBCs. Once they enter into the RBC, they try to non-enzymatically glycosylate or glycate the valine residue of your beta chain. So, as long as you have high levels of glucose in blood, they continuously, passively, without the requirement of any enzyme, they like it on a regular basis. So, when we look into this particular HbA1c, we will get overall average, the last 120 days average of glucose. And around 90 percentage of the accuracy of this will belong to the last 2 to 3 months only. Only 10% from the fourth month. Okay, previous 3 to 4th month. Only the last 2 to 3 months, 90% of the glucose will correlate with HbA1c, and around 50% of the last 2 months average will also be reflected by your HbA1c. Okay, and usually when you look into it, I have already explained you in the basics chapter. You may see the graph in a HPLC, high performance liquid chromatography. You will have multiple graphs, labile graphs, stable graphs, multiple graphs would be there. In that, the HbA1c graph alone, you will have to look. So whenever there is a problem with this GLUT1 channel, or whenever there is a problem with that particular beta chain valine residue, like that can happen in HPF varieties, in other thalassemia varieties and all. When the hemoglobin molecule per se is distorted, HbA1c would be altered and it will not be reliable. In such situation, you will have to look into the fructosamide. Okay, so that will give you an idea. So moving on to the diagnosis, the first diagnostic criteria should be an A1C more than or equal to 6.5, and it should be performed in a laboratory using a method that is NGSP certified. I told you what is that, and that should be standardized according to the DCCT assay. Okay, or a fasting blood glucose more than or equal to 126. And fasting should be defined as no caloric intake. You can take water, but no caloric intake for at least 8 hours. That is fasting blood glucose. And second thing, 2 hours plasma glucose. Sorry, not blood glucose, plasma glucose. 2 hours plasma glucose of more than or equal to 200. Okay, during a OGTT, not a random protein postprandial. During OGTT, and the test should be performed by WHO standards. You should take a glucose load that is equivalent to 75 grams of anhydrous glucose dissolved in water. You will have to dissolve it within 100 to 200 ml of water, and you will have to consume it within 5 to 10 minutes. From the start of consumption, you will have to wait for 2 hours, and at the second hour, when you check the postprandial glucose, it should be more than or equal to 200, or in any individual with symptoms suggestive of hyperglycemia. It could be osmotic symptoms, or it could be some other microvascular complication related symptom also, whatever symptom it could be. Your random blood glucose, if at all, if it is more than or equal to 200 milligrams, then it can be considered as diabetes, irrespective of the meal. That is random. Okay, so this is the exact diagnostic criteria for diabetes. And if you look into impact fasting, it should be 100 to 125. According to ADA, impact fasting is more than or equal to 110. Okay, but according to WHO, it is 100 to 125, and impact glucose tolerance is somewhere between 140 to 199, and A1C of 5.7 to 6.4. Okay, so these are all the diagnostic criteria for a pre-diabetes and diabetes. So, capillary blood glucose is not recommended for diabetes. Venous plasma glucose is always best to determine the blood glucose. And when you take a sample, the particular sample should be either in an ash tube. It will have fluoride, and the fluoride will prevent unwarranted glycolysis from happening. And it will be immediately separated after collection. Immediately, the plasma has to be separated, or else the red blood cells will start utilizing the glucose. And on an hourly basis, 5 to 8% drop of blood glucose will still happen at room temperature, because the RBCs will continue taking the glucose, and thereby there will be a drop. That is the reason why it should be immediately centrifuged and the blood glucose has to be analyzed. So this is with respect to the criteria and definition. Now moving on to the classification. So this is how a classification goes about in diabetes. We have four: type 1, type 2. You have a miscellaneous group, which is also called as specific types of diabetes. Among that, which is type 3. In that you have A, B, C until I you have. And you have a type 4, which is nothing but gestational diabetes mellitus. So these are all the four main classifications of diabetes. So we will see the pathogenesis of each and everything separately. But among the specific categories, type 3A is called as MODY, which is a single gene diabetes mellitus. You have a genetic mutation happening in the insulin secretion. Okay, so 1A is a mutation directly in the insulin secretion pathway. The mitochondrial diabetes is also categorized under single gene disorders only. And B is transient neonatal diabetes. Permanent neonatal diabetes comes under MODY category. Transient neonatal diabetes comes under 3B. And 3C is pancreatic diabetes. So any pancreatic diabetes, be it autoimmune destruction, only exocrine and endocrine, or be it infection related, be it environmental toxin related, be it fibrocalculous pancreatitis, be it cystic fibrosis related pancreatitis, or any trauma and trauma induced pancreatitis also. If there is a problem in pancreas, it is 3C. And D is something concerned with your genetic mechanisms. So herein you have a problem in the insulin receptor. So it could be a 3D diabetes. So we will see in detail. And E is endocrinopathy. You have other counteractive endocrine issues. Like you have high cortisol level, high growth hormone level, high thyroid levels, low thyroid levels, or anything like a pheochromocytoma where you have high catecholamine surge. All these things come under 3E. And F is all about destruction. So chemical or drug induced comes under F. And G is infection related. Okay. H is uncommon, very, very rare complications like stiff person syndrome or insulin receptor antibody. You have an underlying autoimmune disorder and you will have insulin receptors. Okay. Not insulin receptor antibody. Okay, anti-insulin receptor antibody. All these things come under this. And I is all syndromic. So always to confuse you, to trick you, they may give you sections like this. They may give you a particular clinical scenario and give options like 3A, 3B, 3C, 3F and all. You always be thorough. It would be like a memorizing part, but always be thorough about the different categories of diabetes under the three. Okay, and gestational DM we will see. So before going into the diabetes, some words about the basic glucose metabolism has to be addressed. So you have to know what is a fasting state and how is insulin and glucagon going to behave in a fasting state, and what is a fed state and how they are going to behave. So normally there are for regulating a glucose homeostasis, there would be multiple organs coming into play. Not only your insulin, not only your glucagon would be major mediator here. Apart from your glucose, you will have free fatty acids coming, you will have liver coming to effect, a muscle coming into effect, adipose tissue, your gut hormones like your incretin hormones will come into play. All these things play an important role in the glucose homeostasis. Normally, what happens in fasting? When your body is fasting for more than 8 hours, your blood glucose will usually drop. Once the blood glucose drops, your insulin levels also drop. Beyond a level of 70 milligram per dl in your blood, your insulin level will start dropping. And simultaneously, your glucagon will start hiking up right now. Once glucagon hikes up, it makes sure your glucose level in the blood is maintained continuously. You never land up in hypoglycemia. So what glucagon will do is, it will go and it will stimulate glycogenolysis. Okay, so it will go and it will stimulate the liver glycogen breakdown process. So glycogen breaks down and your glucose is released from the glycogen part. And as time goes by, your gluconeogenesis also comes into effect. This is mainly because of glucagon stimulation. The other important reason for gluconeogenesis to happen is low insulin level. So once insulin level goes below, insulin, as you all know, is an anabolic hormone. Okay, so what insulin does is, once glucose increases in your blood, insulin will also start increasing. So this insulin will usually go to the skeletal muscle. What are the insulin sensitive structures in your body? Can anyone tell me? There are three insulin sensitive structures. Muscle, very good. Two more. RBC is not insulin sensitive. Remember, the mnemonic has, okay, hepatic region, adipocyte, and skeletal muscle. So liver, adipose tissue, and skeletal muscle. All the three parts would be insulin sensitive. So whenever the glucose spikes up, your insulin also starts increasing. How does insulin increase? We will see now. But insulin increases, and this insulin will now try to contain your glucose in the blood. What it does, how does it do? It usually pushes the glucose into the liver towards the glycolysis pathway as well as your glycogen synthesis pathway. First of all, it tries to generate energy, but if energy is adequate, it slowly pushes the energy towards anabolism. So what it does is, within the liver, it pushes towards glycogen formation. In the skeletal muscle, what it does is, it will open up insertion of GLUT4 channels into the cell membrane. So this GLUT4, under the influence of insulin, gets inserted into the cell membrane, and it takes in the glucose into the skeletal muscle, and inside the skeletal muscle, glycogen formation will start happening. What happens in adipose tissue? Takes the glucose and it forms triglycerides. Lipogenesis pathway is activated. So if you look closely, insulin is promoting glycogen storage in your liver as well as in your skeletal muscle, and it increases the lipogenesis. So it's more of an anabolic hormone. Okay. So what happens in prolonged fasting is that glucose drops. So insulin also drops. So automatically lipogenesis will not happen, lipolysis will start happening. Okay, so these free fatty acids would be released into the circulation. Similarly, beyond a certain fasting state, like when it goes for hours and hours together, even your protein starts breaking down. So this is about your fasting state and fed state. So normally 8 to 12 hours after a meal, there would be low insulin level and glucagon release would be increased, and gluconeogenesis and glycogenolysis would be activated. Normally when you eat after a meal, with the glucose spike, insulin also will be released, and this increases the glucose uptake, glycogen synthesis, and simultaneously, due to the insulin and glucagon crosstalk, when insulin increases, glucagon will lower. They will have a reciprocal relationship. When insulin reduces, glucagon will spike up. This happens in any healthy pancreas. Okay, so when in diabetes, what happens? This reciprocal relationship would be completely disrupted. So even in the pancreatic beta cell and alpha cell, the crosstalk will not be there properly. So despite having normal insulin or high insulin, your glucagon will still be high, and it will not allow your body to bring down your glucose at all. Okay, so this is the problem that happens in diabetes mellitus. Okay, so this is the basic thing that you will have to know in any metabolism. So normally what happens when glucose increases in your blood, it enters into the pancreatic beta cell. So beta cells of the pancreas. Once it enters into the beta cell, it utilizes the rate limiting enzyme, which is called as glucokinase. This is the rate limiting step. This pushes it towards the glucose 6-phosphate formation, and finally, out of glycolysis, pyruvate will be generated. This enters into the mitochondria towards the oxidative phosphorylation, and ATP energy production will happen. Once adequate ATP, that is the ATP to ADP ratio, when you look into it, when you have high ATP and low ADP, when you have high ATP, this will activate your ATP sensitive potassium channel and close it. Okay, so this closes the ATP sensitive potassium channel. The main function of the ATP sensitive potassium channel is to push the potassium outside. So once it gets closed, potassium starts accumulating inside, and this membrane gets depolarized. Okay, excessive depolarization now will activate your voltage sensitive calcium channels. Once they are activated, calcium will come inside from exterior. Okay, and this calcium will usually bind with calmodulin and activate myosin light chain kinase. Okay, once myosin light chain kinase is activated, automatically your myosin would be phosphorylated, and along with the actin, they increase the transport of these vesicles. They help in the docking of the vesicles to the plasma membrane, and they help in release of the insulin which is stored in the vesicle to the exterior. Okay, simultaneously, what they do again is this calcium calmodulin along with the myokinase complex will also activate the transcription factors which are needed for insulin synthesis. So you have certain transcription factors called PDX. A lot of transcription factors are there. Some transcription factor like PDX would be activated. They are activated and they go and sit inside the insulin promoter region of the gene. Okay, in the insulin producing gene, you have an insulin promoter region. These transcription factors get stimulated, they go and sit in the gene and they increase the transcription and translation of insulin production. So the first phase insulin production is due to the release of previously stored insulin. And the delayed phase insulin production is due to the active machinery of the islet cell, which continuously increases the production of insulin as long as the stimulus of glucose is there. And this is affected by means of the transcription factors. Okay. Once more, I will tell when the glucose comes inside, it enters through the GLUT channels and it enters into the cell. The rate limiting step is glucokinase. It forms glucose 6 phosphate, enters into glycolysis, pyruvate is formed. Pyruvate enters into mitochondria, oxidative phosphorylation, ATP is generated. ATP will now close your ATP sensitive potassium channel. It causes depolarization. Once membrane is depolarized, it activates the voltage sensitive calcium channel and calcium comes inside. Calcium now activates myosin light chain kinase, and this myosin light chain kinase, calcium, cal bond, and all these channels together will have two activity. Activity one, immediately it will allow the docking of these vesicles to the plasma membrane, and they help in the releasing insulin, preformed insulin into the portal circulation. And secondly, it will also activate the insulin genes, and that way you will have insulin production. Okay, the first phase and delayed phase of insulin secretion. If you look closely now into this again, this potassium, no, ATP sensitive potassium channel will have one more receptor on the surface of it that is called as sulfonylurea receptor. Okay, so only in this receptor your sulfonylurea will come and act. So we are bypassing this entire process here. Okay, okay, so we are bypassing this entire process here and we are directly stimulating the sulfonylurea receptor. We give glimepiride, we give glycoside, you give glibenclamide, whatever it is, it's going to activate the sulfonylurea receptor. And this activation is going to close the ATP sensitive potassium channel. And directly it will increase the insulin secretion. But remember, this process glucose independent, and that's the reason why you end up with hypoglycemia when you give sulfonylureas. Okay, and simultaneously, if you see, you have one more thing here, which is incretin receptor. What are the incretins? You know, can you name the incretins? GLP analogs are not incretin. GLP is an incretin. What else? GLP is one. The other incretin is GIP. So glucagon-like peptide, glucose-dependent insulinotropic polypeptide. That is GIP. Okay. Glucagon-like peptide, as the name indicates, it looks like glucagon, but it is an incretin. What is an incretin? Incretin is more like a gut hormone. This GLP is produced by the L cells of your small intestine. Usually, they are also seen in the late part of your large intestine. Okay, and GIP is produced by the K cells of your duodenum. Remember L for L, okay, and K cells of your duodenum, small intestine. So once any food goes inside your body, like a glucose or a amino acid or whatever it goes inside, these hormones are stimulated. So they go and they have varying functions. GLP, what it does do is that it will have a glucose dependent insulin secretion. That means only if the blood glucose is more than 70, this will go and activate the insulin secretion. Okay, so only if glucose comes in your blood, GLP and glucose both they go and activate your incretin receptor and your insulin will be secreted. That is the main reason when you use GLP-1 analogs, even at a higher dose, they don't cause hypoglycemia like your sulfonylureas. Okay, sulfonylureas have glucose independent insulin secretion. This has a glucose dependent insulin secretion, and they activate your insulin pathway through cyclic AMP production, not through your protein calcium. It leads to cyclic AMP production. Okay, so this incretins. What are the other functions of incretins? The first and fourth we will deal with in detail in obesity chapter. But just from the diabetic perspective, the points that you will have to know is they are produced by L cell and cases that part of your duodenum and large intestine. The second thing, GLP will increase your insulin secretion, and that is a glucose dependent insulin secretion. And third thing, they delay the gastric emptying. They slow down the peristaltic phase. Okay. The fourth important thing is GLP in specific, okay, will suppress the glucagon secretion because GLP is a molecule which mimics the glucagon. So glucagon, insulin, dysrhythmia would be there. No, that will not be there in this condition. So it usually suppresses your glucagon secretion. Okay, so this is the main thing that you will have to know about the ingredients. So this is how insulin is produced. You have a pre-proinsulin which is further undergoing proteolytic cleavage, and you get a proinsulin, and finally you get a insulin proper. You have a A chain and B chain. A chain will have 21 amino acid and B chain will have 30 amino acid. Overall, it is 51 amino acid, and you have a C peptide also. And you see disulfide linkages between the two chains of your insulin, and they are stored together in vesicle, and once they are released into the stream, insulin C peptide, they part ways. But what is the clinical significance of C peptide? C peptide's clearance rate would be very slower compared to of the insulin 2 to 3 minutes hardly in blood, but C peptide usually will be there for a longer time, say 20 minutes. So when you look into the C peptide, the beta cell reserve, and when you're talking about treatments and all, the treatment responses can be monitored for classification of the diabetes, whether it is type 1 or type 2 diabetes also. It may give you an overall idea. So C peptide, it has various other roles also. Okay, doesn't have much of physiological role, but at least for a diagnostic purpose it is of immense role. Okay, you also have an islet associated amyloid pancreatic polypeptide, which is usually stored into the beta cells and it's also secreted along with your insulin. Okay, so this is how it is related. So I think we are clear about this part now. Now we will go about the insulin action part. If you look here, insulin, like as we previously discussed, it is a tyrosine kinase receptor. You could see the extracellular part, transcellular part, and the intracellular part of your insulin receptor. Once insulin binds to the insulin receptor, heterodimerization happens, and this increases the docking of all these insulin receptor substrates. Once the insulin substrates, or depending on the type of the docking, the resulting mechanism, downstream mechanism will usually vary. Just remember these three part, very very important. You have AKT pathway, you have MAP kinase pathway, and you have mTOR pathway. This AKT is very 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 important because that is involved in the metabolism. So it is involved in glucose uptake, glycogen synthesis, and cell survival. If you look into the MAP kinase, mitogen activated protein kinase, mitogen activated, so obviously it's going to be of mitotic benefit. So cell growth, differentiation, proliferation, that is activated by MAP kinase pathway. The third important thing is mTOR pathway, which is an anabolic pathway. Okay, so that is involved in protein synthesis and cell growth. So all these three pathways, depending on the type of the insulin receptor substrate that is getting activated, depending upon the intensity of the stimulus, each pathway will differ. Okay, and each pathway activates one particular area. What we are concerned about is the AKT pathway because it is going to take the metabolic control. Okay, be it a glucose GLUT4 channel insertion, or be it glycogen synthesis stimulation, or be it cell survival, everything is managed by AKT pathway only. So see, GLUT4 insertion is happening, and cell vesicles, insulin release. Further insulin release is also mediated by the insulin. So everything is mediated by insulin. Gluconeogenesis is usually inhibited by the AKT pathway. So what are the insulin action? GLUT4 insertion into the cell surface, glycogen synthesis will happen, inhibition of gluconeogenesis. I told you already, lipogenesis, triglyceride deposition in the adipose tissue, protein synthesis on longer run, cell growth and differentiation. And two more important points that you will have to know is it moderates immune response. That is the main reason why in diabetes you have so much immune dysregulation, so much anti-inflammation happens. Okay, regulation of the blood flow because it stimulates the release of nitric oxide and other vasodilator. Have you ever heard in DKA, even before giving insulin, you have to replenish the patient with adequate hydration, because once you give insulin, insulin is going to activate your nitric oxide and it is going to increase the blood flow, and thereby there will be a rapid hypotension happening if you are not hydrating the patient and if you are going to give insulin alone. Okay, that is the main reason. This is the main reason because insulin has a direct stimulatory effect on the nitric oxide release. Okay, so these are all the functions of insulin.